Hi, I'm Lauren Harkins. I am Assistant Director of Programmes in the NHS Transformation Directorate, which was formerly NHSX.
And good afternoon, I'm Nicola Hayward-Alexander. I'm the System CIO at Lincolnshire Integrated Care System.
So really pleased to be here today talking to Nicola about a project that I know she is incredibly passionate about, which is the Atrium in Lincolnshire. We've been having conversations about this for, it feels, about a year now. So really pleased that she can share the vision, the story, and really how it's something that we see that could potentially be a model for scale across the country. So really over to you, Nicola, to sort of introduce the Atrium and really tell everyone what it's about.
Thank you very much. So the Citizen Atrium, or the virtual Citizen Atrium, is around taking the concept of a marketplace, but we know that marketplace is not really the right concept we would want to introduce into health and social care services and indeed wider public services. And the notion of the word atrium comes from the context of, if one imagines in a very large hospital, you walk in through the front doors and the first things you see is a little bit of signposting and direction and things you can do, and then you might decide to interact with one of the charities who may be offering services that would be useful to you. You might want to go and put your prescription in at Boots, maybe buy a few other things while you're there. You maybe then want to go along to a session that might be available, so again through one of the charities, and then eventually you'll go through the door into the wider hospital where clinicians and healthcare professionals take over and take you through a guided pathway. And we wanted to be able to provide something like that, but in a virtual world, knowing that today a lot of people want to be able to do these things on their tablet or on their phone, particularly in Lincolnshire, where people possibly are having to undertake 1 hour plus journeys to get to a hospital or a specialist centre of sorts. They may even be having to go further afield if they are trying to access specialist support that's coming from outside of the county. If I was to say 20% of our mothers do take services from outside of Lincolnshire if there is any sort of complication with pre or post natal their pre-postnatal requirements. And that's just one example. We already had within Lincolnshire a website that provided people with access to advice and guidance, and that cut across all aspects of public service, including health and care, so even things like support over benefits, care allowances, housing, etc. But that was a very static site, shall we say, which meant people needed to go and find that site, and then they needed to sort of navigate to where they could get the support. We'd also been developing some capabilities in which we were supporting patients and empowering them in terms of self-management around conditions such as diabetes, pulmonary and cardiology rehabilitation, stroke rehabilitation, mental health, and going as far as even working with young people to redesign IAP services into a chatbot provision so that they could self-manage. What did struck us was, what if we put this on a platform where this is all in one place, and even better, what if we started to use the capabilities of relationship management software? This isn't necessarily a type of software that people use readily in health and care, has been my experience. I come from a background of private sector, then government, and then higher education, and we've been using relationship management software in those sectors to help us better understand how our customers or citizens are interacting with the online services that we are providing them. That then provides us with intelligence to understand how we can continually improve those services and improve that access and understand better the sorts of help that they want. And talking to our allied health professionals and our GPs out in the community, one thing became very clear is that they provide an awful lot of support for citizens to go away and help themselves. But when they walk out that door, they don't necessarily know how well those citizens engage with that. So they might give them an exercise sheet, say if they're a physiotherapist, or they might refer them to some type of community activity. We know that we prescribe social prescribing to citizens, but again, we might know how much the charities then recharge the GP for that social prescription, but we don't really know which citizens are taking up which activities. Again, if we put that on a relationship management platform, we start to get much better understanding of what types of cohorts of citizens are interacting and using what capabilities. Finally, imagine then we could then connect this up to a health app library, such as the one that Orca provide, and do something similar around devices. We then start to be able to recommend and direct citizens towards particular applications and devices. We start to be able to do that on a range from self-service right through to prescription. If it's a prescription application or device, we can also then look at how, by creating a cloud account around the citizen can then be the custodian of that data that they have generated using that app or device, and they can donate that back into their shared care record. So the idea was to take the capabilities we already had, but to rebuild that on a Microsoft Dynamics platform as a single ecosystem, which would run parallel to our shared care record and care portal, which is our information exchange.
So I guess one of the things that I'm sure people are thinking is one of the complexities in health and social care is around sharing data without diving sort of too deep into the IG. Can you tell us a little bit about how that works, who has access to the data, and how that ultimately really benefits the citizen?
As I'm talking, I'm going to just leave some patient stories on the screen for you. There is 4 in total that we've generated with our citizens. I'm not going to go them in detail, but as we work through, I'll just leave them on the screen, and we'll move through them every few minutes. Going back to the question that you just asked, obviously one of the key concerns primarily for our health and care professionals is their responsibilities as data custodians. What we wanted to do was create a situation where data that the citizen is generating within their own personal cloud account is their data to choose as to how they want to donate and how they want to use it. And at any point, when they join the Citizen Atrium, they become a member of the Citizen Atrium, just like in the same way as if you join a squash club, say, for example, or a film club or something. You would go through your terms and conditions, and you would decide how your data may be used. And in terms of us using that data to understand how they are accessing services, our citizens would be supported by a digital navigator who would explain how we would use that data and ensure that the citizen was satisfied with how that data was being used. Once the citizen starts to create data around themselves through a health app or through a device, that data is still there. So those of you who use anything like Fitbit and have got an app on your phone and there is data sitting on your phone, that is your data. You are the custodian of that. But you may wish to donate a proportion of that data. It may be that you've gone to see your GP, you haven't seen your GP for 5-6 years, but you're starting to feel a little bit dizzy from time to time, and your GP thinks, actually, if you could give me the last 2 months or the last 2 weeks even of your blood pressure data from your Fitbit or other such device, donate it to me, and then I can use that rather than pulling you into the surgery for one ad hoc blood pressure measurement. In that regard, the IG decision lays lying with the citizen. And as the citizen donates that data, they will be asked a series of questions. Do you want this data to be used just for your direct care, or are you happy for this data to be used anonymously for population health planning or other research purposes? So that way, we're giving the citizen the direct control, and we're using the Atrium as a way of communicating with them about their rights.
So thinking about sort of local authorities, councils, social services, how does the Atrium really strengthen the links into those areas, sort of moving outside of health?
So some of the examples that we've been talking about has been, say for example, with this gentleman that we've got up here, this family. This is a mother who has parents that she's looking after, and she also has a child with special educational needs and verbal, he's non-verbal. So she's already working with a wide variety of people across the system. And she's come into a new system as well, so she's now having to learn all those necessary relationships. So she's working with social workers around her parents' care package and social workers around her son's needs. She's also working with educationalists around his education needs, and she's working with health and care professionals both in mental health and in physical health around his physical needs. And this is an example of how through the Atrium, she can have access to the various areas of the system. She can interact with the system from a point of channel of her choice. And also we can link that up with, so we were looking at how would she be able to link this to monitoring devices in mum and dad's home? How would she be able to use this to interact with teachers? She'd be able to see what her son is telling his teachers about how they are thinking, because they could link this into a Makaton app. A Makaton app is where children who are non-verbal use Makaton to communicate with their teachers, and may use that to say how they're feeling on that day. And this would give her direct access as well to those communications, so the teachers could immediately have conversations with her about what is best for her son. So we're seeing that this provides more than just a means of working in your more traditional health service context, but we also see it as a way of being able to look at somebody's complex needs where they are wanting to work with a wide variety of public services. So those could extend to things like housing, benefits, police, education.
So what have the real challenges of this been in terms of establishing it, and sort of where do you see this landing in the future?
I think when we started, we thought the real challenge would be looking at how we could take the current technologies that we have got and pulling them together as one single ecosystem and developing the architecture. It's turned out that over the last year, developing that architecture, working with a consortium of suppliers, has not actually been our biggest challenge. Our biggest challenge has been actually getting the funding, and then once we've got the funding, getting the funding into the system, and then being able to agree who within the system would host this on behalf of the system, procure the suppliers. We've gone as far as the latest thinking has been around working with one of Microsoft's gold partners and them acting as the lead for the consortium and subcontracting the developers that we want to work with. And also we've been talking about how we can develop our own local skills. So within our devs department, having a centre of excellence in the same ways we currently do with Power Apps, doing something similar around CRM systems. But the other beauty around something like the dynamic CRM system is that it is actually highly configurable, and we've started to do some work with some of our digital nurses working in cardiology and in stroke rehabilitation, and looking at the possibility of them being able to do a certain degree of configuration so that they could develop pathways and ways of interacting and providing self-help services that would guide their patients to the different applications, online activities that they could do. And we've had very positive feedback from them. Again, the problem has actually been that although colleagues like yourselves have been really enthusiastic about it, and we've been awarded £3.3 million through the Elective Care Recovery Fund, even today, as we're having to close down accounts, we are struggling to clarify how we can get that issued to us as a grant, how we can ensure that that's not bringing additional costs and burdens to the system through things such as capital charges, etc. And you and I know that sadly sometimes what we think is going to be the difficult thing, which is clinical engagement and the technical complexity of it, and getting a consortium of suppliers to work together as a partnership, all those things have been a breeze compared with how do we facilitate funding through our highly complex health and care system.
And sort of touching on that, I guess the health and social care system is evolving. We're moving towards ICSs. Sort of how do you really see this fitting into that total ICS model in the future?
I'm really conscious at the moment that there are 42 ICSs and They all have different views on how they're going to interpret the guidance, including the one that I work for. My personal opinion, and I must be very clear, this is not the opinion of the ICS I work for, my personal opinion is that it's really important that we are delivering data in digital from the heart of an ICS under the authority of the ICBs, who will be legal bodies in their own right. And that would help an awful lot, because an asset like this should ideally sit with a central body like that, in order that it can reach that multitude of public services and provide the sort of joined-up benefit that actually citizens need. I've been a carer myself, and I've seen for myself how complex and difficult it is to ensure that you are on top of and managing all the care. In this case, it was around my mum who had Parkinson's. I found that I was having to draw an awful lot on my knowledge of the inner workings of the health and care system, and I often used to think, goodness, how is this for people who don't have that privileged information and contacts that I've got?
Absolutely. I was going to see if we've got time to open... there's a hand up. Open up for any questions. 4 minutes, open up to any questions from the audience.
This sounds and looks amazing. First of all. So first question, access through the LHIS app, so that you manage ideally through there and you can point towards other things. And then the second thing is does it actually get to the business end of LHIS transactions? So can I link in to see my GP record? Can I link in to see my personal health record? Can I see upcoming outpatients appointments, for example?
So we've been mapping the citizen's journey, and we see the Citizen Atrium as sitting alongside our care portal, which is where our shared care record and where we manage what I would refer to as the clinically led, professionally led pathways. And within the care portal, we have a patient portal. So what we're doing at the moment is we are just integrating our patient portal and care portal to the NHS app and NHS login. The idea would be is that we would then position the NHS app within the Citizen Atrium. So if you see this picture on the left-hand side, what people have is they have a screen with lots of windows. If you think about sort of your standard sort of Microsoft Windows environment, lots of windows with different sort of doorways to different services. One of those things would be your NHS app. So therefore you'd be able to move into that environment, and then you'd be able to go in and you'd be able to see the detail around your shared care record, or if you were an advocate, the record belonged to the person that you were providing the support to. When we come to looking at direct prescription, the idea with prescription is where it's social prescribing or it's device prescribing, that might be we are recommending a device, or we're actually going to give you a device, or it's application prescribing. So again, people would be able to either use the app library to identify an app they want to use, or a professional might prescribe an app library. Through the prescribing mechanism, we would have, with those particular apps, we would have built a back-end API, and that's where the data would get donated.
Yeah, no, great question. I think, we've got a real opportunity over the next couple of years with the NHS app. So we've gone in the past 12 months from sort of circa 2 million users to 24 million users. So now we're almost at 1 in every 2 adults in the country has and is actively using the NHS app, which is a huge shift. I think we've got time for one more question, if anyone has one. Oh, gentleman at the back.
Sorry, could you speak up slightly? I'm struggling to hear you.
Yep, so I think the question is if the patient, so you talked about the patient giving permission to share their data. What happens if the patient doesn't give permission to share any data?
Bearing in mind that if the patient is receiving direct care, and we already, and patients have given permission or they've not given permission within the direct care model, that's how they would continue, or not continue to get that level of service. This is around being able to empower patients to do those activities above and beyond those that are directed by a clinician or by a healthcare professional. So let's take, for example, a patient who is very conscious about their privacy. Maybe that they are, they've got a high-profile role and they are generally fit and healthy, but they have had some sort of addiction issue or mental health issue, and they want to keep that private. They may have opted into, in terms of their direct care, to keep their record quite closed down. So the Mental Health Trust may be treating their record with a quite high level of privacy and have put quite strict auditing processes around it. That individual may also get directed to use an application to help them with their day-to-day well-being, that may be some type of app that helps them with their mood and to monitor that. And that patient can just decide that I'm not going to share that data anyway, that's just purely for my use. And it may be that when they sit down and have a video conference or they have a face-to-face appointment with their professional who is helping them, they may just, in that case, they may choose to sort of take their tablet along and share the information in that way within the confines of that single one-to-one consultation. But because the data they've generated using the apps to support them personally is their data, that they don't have to share that at all. And any data that's been generated through their professional consultation will still have the level of privacy they have agreed with the organisation providing that care.
Nicola, Lauren, thank you so much. I'm sure this conversation, can naturally continue. We'd like to please thank our fireside chatters this afternoon, Lauren and Nicola, and I'm sure we'd love to hear so much more from you. So thank you.